Hello, very good evening to all of you in the audience. My name is Vikram Ganju. I represent iGenomics in India. And I would really, thank you all for sparing your time for today's session on endometrial receptivity analysis. Once again, thank you very much for your time and being here with us this evening. This session basically is to, furthermore educate you about what are the recent developments on ERA, endometrial receptivity analysis. And the session will be taken over by none other than Dr. Maria Ruiz Alonso. She is the clinical manager of Endometrial Receptivity Analysis Lab in Spain, headquarters, Valencia. So I would welcome Dr. Maria. She's already with us. Dr. Maria, thank you very much for being here with us today to, carry out this webinar. And thank you very much for your time. But before I hand it over to you, Dr. Maria, I would just like to give a brief description of yours, to the audience, so that, audience is quite familiar with you, like who is taking up the session today. Yeah, thank you very much. Well, Dr. Maria Ruiz has been associated, with the study of research and study of endometrial receptivity analysis past 11 years at iGenomics Spain. Dr. Maria has received her bachelor's degree in biology at Murcia University, Spain. And initially, she was a lab manager of ERA lab, and now she is the clinical manager of endometrial receptivity analysis lab at iGenomics headquarters in Valencia, Spain. She has been focused throughout her, career on the endometrial factor related to infertility, specifically on the displacement of window of implantation. As well, the personalization of the embryo transfer, what we call it as PET. In her research, Dr. Maria Ruiz, over all these years, has published various articles in scientific journals like Fertility Sterility, Human Reproduction, BBA, Molecular Basis of Disease, and Cold Spring Harbor Prospective in Medicine. So once again, I welcome Dr. Maria on behalf of iGenomics India and on behalf of the audience. Thank you very much, Dr. Maria. Now I would like to hand over the session to you. But before I hand over the session to you, yes, very important, very important. I would request the audience, one and all, if you have any questions, you will see there is one question box, on the screen. You can just click on that, write down your questions, because unfortunately this webinar has one, restriction that it's a one-way kind of a traffic. So you can just put your questions in the question box, and once the session ends, I'll be reading out your questions to Dr. Maria for her replies. Thank you very much, and let's begin, Dr. Maria. The floor is all yours.
Okay, thank you so much, Vikram. It is a pleasure for me to be here to show you, well, some scientific aspect of the endometrial receptivity analysis test. So let's start with the presentation. Okay. So this is the summary of what we are going to see today. First of all, I will review briefly the endometrial receptivity concept. Then we go through the endometrial receptivity analysis, the ERA test itself, by analyzing which is the meaning of personalizing the window of implantation and how we personalize the embryo transfer. Then we will see the clinical application of the ERA test by checking these three main points: ERA requirements, ERA indications, and ERA global data obtained during these 10 years in which we have been applying ERA at clinical level. At the end, I want to show you the personalized embryo transfer outcome obtained at different levels in different publications, and finalizing, we will see the conclusions. So let's start first. We already all know that the embryo is not able to implant in the endometrium at any moment of the cycle, but just during a few period of time called window of implantation, which usually used to be considered to be between day 19 and day 21 of the cycle. But is there an optimal day for the embryo transfer, and which will be that day? Well, usually and classically, it has been considered that the endometrium reached the receptive phenotype after 5 full days of progesterone exposure, which will be P+5 in an HRT cycle or LH+7, HCG+7 in natural cycles. So a patient that has a standard window of implantation will result receptive if we analyze her endometrium at progesterone +5. But we have detected that not all the women has this kind of result, but some of them are pro-receptive at progesterone +5, so their void is delayed, or post-receptive, so their void is advanced. This is what we call a displaced window of implantation, because this endometrium needs a different timing of progesterone exposure to reach receptivity. And how can we detect that? Well, with the ERA test. What we did to develop this test is to analyze at transcriptomical level the different endometrial stages. This is, by collecting samples from women at different moments of their cycle, we were able to know these transcriptomic profiles. This is how the genes were being expressed at different moments of the cycle, and taking like a picture of all of the different endometrial stages. With this information, we are able to know when the endometrium is receptive based on the expression of specific genes. What we see is that those samples that were collected during the pro-receptive stage match perfectly between them, or during the receptive stage or during the post-receptive stage. This is, the transcriptomic profile is able to classify the endometrium in one of the different endometrial stages. With this information, what we do is to develop a test based on the gene expression level of 248 genes, and with that value of gene expression, we trained a bioinformatic predictor. This predictor, coupled to the analysis by next generation sequences of the 248 genes, is what we call ERA test. This was published in 2011, but at the beginning of the test, we were using microarrays. Now, from 2017, we are using next generation sequencing. And these are the value for global accuracy, mean sensitivity, and mean specificity of the test. When we are using the endometrial receptivity analysis, there are different scenarios that we can find, depending on how the endometrium of the patient answers to the progesterone exposure. So what we do is always collect a first biopsy, endometrial biopsy from the fundus of the uterus at the day designated like a standard window of implantation. This is progesterone +5 in HRT cycle or LH+7, HCG+7 in natural cycles. So with the endometrial biopsy collected at the fundus of the uterus, we are going to extract RNA, means messenger RNA, and we are going to sequence this messenger RNA, obtaining the gene expression value for 248 genes. It can happen that we find a proliferative result. What does mean? That the endometrium has not been exposed to progesterone, or that it is not able to answer to progesterone. because a proliferative endometrium means that the endometrium has not started to the secretory phase. So usually when we obtain this kind of profile, we are going to request a new biopsy because in most of the cases, this result is related to some issue during the endometrial preparation protocol. Maybe the patient forgot to take the progesterone, or maybe it was not properly taken. There is just few cases in which we obtain a very proliferative result after a proper endometrial progesterone taking, and this used to be related with specific conditions, like for example, patients with an embolization of the uterus, for example. Other possibility is that we find that the endometrium is pre-receptive. Then we have two options. It could be early pre-receptive, that means that the endometrium needs 2 more days with progesterone exposure to reach receptivity. In these cases, we will need a new biopsy 2 days later. This is if the first biopsy was collected at P+5, then the recommended biopsy will be at P+7. Or it could happen that the result is pre-receptive, but the endometrium needs just 1 more day with progesterone exposure to reach receptivity. And in such case, we are going to recommend directly the personalization of the embryo transfer by adding 1 more day with progesterone exposure. This is, in this case, you can see the early pre-receptive scenario. We will recommend a second biopsy at P+7. And here we will recommending add the personalized embryo transfer at P+6 because it is needed just 1 more day with progesterone. On the other hand, we can find a receptive profile that could be optimal receptive, and then we will recommend just to replicate exactly the same down for the biopsy cycle. Or we could have a late receptive profile. This means that we are at the end of the receptive period, and then we are going to recommend to rest 12 hours of progesterone exposure in order to be in the optimal receptive profile. Finally, we can obtain a post-receptive result. That means that the endometrium needs less time with progesterone exposure, usually 1 day less. And in this case, we are going to recommend a new biopsy to validate the predicted going. You can see here that in some cases we are requesting a new biopsy, and in other we are recommending directly the personalized embryo transfer. In most of the cases, we are going to obtain this result, pre-receptive 1 day, receptive or late receptive. This accomplishes more than 90% of samples that we receive. And these cases, proliferative, early pre-receptive or post-receptive, are less than 10% of the cases that we receive. But in these 3 cases, we are going to need a new biopsy. Why is this? Because we did a paired biopsy verification analysis to test which is the accuracy rate of each prediction. So, an example. A sample collected at P+5 that result pre-receptive needing just 1 more day with progesterone, we collected a second biopsy in the recommended day, and we analyzed the rate of receptivity. What we found is that in cases in which we are recommending just 1 more day with progesterone, 89% of patients reach receptivity by following such recommendation. This is a very high accuracy rate, so for that reason, we don't need a new second biopsy validating the predicted window of implantation. But this rate is not so high when we obtain a first post-receptive profile or an early pre-receptive profile. In such cases, we have an accuracy rate of 70% for early pre-receptive or 60% for post-receptive cases. For that reason, when we obtain an early pre-receptive or a post-receptive result, we always keep suggesting a new second biopsy, but not for the pre-receptive that needs just 1 more day. And what we do when we have the result of the ERA? Well, we have to transfer the blastocyst according to the result obtained. We are always going to transfer the blastocyst. It doesn't matter if it is day 5, day 6, or day 7. Once it has reached the blastocyst stage, we are going to transfer it at the receptive day of the endometrium. But if we want to transfer a day 3 embryo, we will have to do it 2 days earlier. This is, in example, a patient which was receptive at progesterone plus 4 will have a blastocyst transfer at progesterone plus 4, but a day 3 embryo transfer at progesterone plus 2. So which is the clinical application of ERA? Well, the process is very simple. It's just collecting an endometrial biopsy from the fundus of the uterus at the standard day for the window of implantation. Then we will do the RNA extraction, we will do the sequencing process, and then we will release a report with the indication about how to personalize the embryo transfer or when to collect a second biopsy. But which are the requirements to be sure that we are doing properly the ERA test? First of all, we have to keep in mind that to ensure the reproducibility of the result, it is needed to replicate the same conditions done in the biopsy cycle. This is, if I collect the biopsy for ERA in an HRT cycle, it is needed that the transfer has to be done also on HRT cycle, because there are patients that can answer in different manner to different types of cycle. Here you can see a pilot study in which we analyze 5 different patients that has 4 different eras collected at different types of cycle. Natural based on LH surge detection, natural with HEG triggering, HRT, and control ovarian stimulated cycles. As you can see here, although there are patients that answer in the same manner to the different types of cycles, there are others that result non-receptive or receptive depending on the type of cycle. For that reason, in order to be sure that I am transferring properly according to the ERA result, I need to replicate exactly the same conditions in biopsy cycle and in transfer cycle. On the other hand, it is very important to collect the first biopsy always at the standard window of implantation. This is independent of the type of embryo that I'm going to transfer later. I mean, even if you want to transfer a day 3 embryo, the first biopsy should be collected at P+5, because we need to know how the endometrium is in the moment in which the blastocyst will be ready for the implantation process. So we always collect the samples, the first samples, at P+5 in HRT cycle or at LH+7, HCE+7 in natural cycles. Also, it is very important to have a proper control of endogenous progesterone prior starting the progesterone supplementation in HRT cycles, because at the end, what we are looking is how many times with progesterone needs the endometrium to become receptive. So, in case that we have a patient in an HRT cycle and the patient has an endogenous progesterone escape prior starting with the exogenous progesterone, we could be thinking that we are collecting the sample at P+5, but maybe the endometrium is already exposed 2 days earlier to progesterone. So we will be collecting the sample really at progesterone +7. For that reason, it's very important to control the endogenous progesterone value in blood within the 24 hours prior the first exogenous progesterone intake, and it should be less than 1 nanogram per milliliter. Otherwise, the cycle must be cancelled. And to whom can we do this test? Well, the main indication for ERA is patients with recurrent implantation failure, because we know already that there is like 30% of patients with recurrent implantation failure that are going to present a displaced window of implantation. So they are going to receive a benefit of doing ERA. Also, we recommend to do ERA in patients with BMI higher than 30. This is because in a study published in 2017, and then in a second study published just last year, we have seen that those patients with high BMI, more than 30, has a higher rate of non-receptive result in their first ERA. This means the patient with BMI over 30 has a higher risk of having a displaced window of implantation. For that reason, it is very important that if we have a patient that has a BMI higher than 30 and she is going to lose some weight prior the transfer, then the ERA should be done after losing weight, because otherwise we could be affecting the reproducibility of the result. Also, it is indicated to do the ERA test on patients with atrophic endometrium. These are the data from another study from 2016 in which we analyzed the ERA result in patients with different endometrial thickness. In the first line, you have patients with atrophic endometrium with less than 6 millimeters of thickness, then patients with normal endometrial thickness between 6 and 12 millimeters, and patients with hypertrophic endometrium with more than 12 millimeters of thickness. And as you can see here, there is a higher proportion of patients with displaced window of implantation in atrophic or hypertrophic endometrium, being statistically significant in the comparison between atrophic and normal endometrium. So patients that has consistently in all hair cycles an endometrium with a lower thickness than 6 millimeters, this will be an indication to perform the ERA test. Also, it happens similar with patients with adenomyosis. What we have seen is that patient that has adenomyosis has a higher risk of having a displaced window of implantation. So it is important that if you have a patient with adenomyosis that you are going to treat prior the transfer, then the ERA test must be done after the treatment. Finally, for this section, I want to show you some global data from 2010 when we started to use ERA at clinical level. As you can see here, if we classify the different results in 3 main categories, we will have receptive, including late receptive results and optimal receptive result, non-receptive, including pre-receptive, post-receptive, and proliferative, and non-result category. That means that this is all the cases in which there is not enough RNA to analyze, or maybe the RNA obtained is of bad quality, or maybe we have a non-informative profile. This will be in this category. So as you can see, most of cases that we receive in the first biopsy are receptive, almost 65%. Then there is a 32% of cases non-receptive, and a few percentage of cases, just 3.6%, has non-result. If we subdivide these 3 main categories in all the different stages, we can see that the most frequent stage is optimal receptivity, which is 61%. Then we have a 5.5% of cases late receptive, and then between the non-receptive category, we will have that almost 30% of patients will need just 1 more day with progesterone. They are pro-receptive, needing 1 day. There is few cases that needs 2 more days or that result post-receptive. As mentioned before, these cases, pro-receptive needing 1 day, receptive or late receptive, have a direct recommendation for personalized embryo transfer. So it is not needed a new biopsy, a second biopsy after the first one. In those other cases in which we request a second biopsy, we see that in more than 93% of cases, with this second biopsy, we are able to obtain their recommendation for the personalization of the embryo transfer. Finally, I want to show you which is the clinical outcome that we are obtaining after personalized the embryo transfer guided by ERA. This is the first case report that we published in 2014, and it is just a case that could be an example of any of the patients that comes to do the ERA. This is a patient that has in a first clinic 2 attempts with fresh embryo transfer at day 3, and they were negatives. Then the patient change of clinics and has 5 more attempts with their own oocyte, but 3 of them with own donation. You can see that there were different protocols, day 5, day 3 transfer, HRT, natural cycle, but none of them work. Then we found that the patient was receptive at progesterone +7, was not tried before. And after personalized the embryo transfer, the patient get pregnancy successfully from the 2 embryos transfer. This is another study that we performed in 2014, in which we have this kind of pilot study was 17 patients. What we wanted to check is what happened in those patients in which we are transferring at a non-receptive endometrium. So here you have the clinical outcome of these 17 patients using ovum donation, okay? As you can see, for the first attempt, the implantation rate was around 13 and the pregnancy rate around 33.5%. In the cumulative outcome, it is also similar, almost 11% for implantation rate and 19.4% for pregnancy rate. But what happened when we personalize the embryo transfer and change the day in which the blastocyst is transferred? Well, you can see here that then for first attempt, the implantation rate increased to 34.5% and the pregnancy rate to almost 53%. The same with the cumulative outcome. The implantation rate increased up to 40% and the pregnancy rate up to 60%. So we increase the sample size to do this second study by analyzing the clinical outcome after transferring a non-receptive endometrium for 52 patients and after transferring a receptive endometrium for 205 patients. As you can see here, we can find also similar comparison. For the implantation rate at first attempt, non-receptive patients had 13%, while when transferring at the receptive day, we obtained a 45% of implantation rate. Similar for pregnancy rate at the first attempt, 23% of patients achieve pregnancy after transferring in a non-receptive endometrium, while if we transfer in the receptive endometrium, 60% of them reach a successful pregnancy. This is what we obtain when in recurring implantation failure. This is obtained from different clinics around the world that share with us their clinical outcomes. You can see here in the first column, patients that were receptive as the standard window of implantation, they had no displacement of the void, and patients that were receptive at a different moment than the standard. Maybe P+4, P+6, P+7, okay? At the end, we are transferring in both cases at the receptive day. So we don't have difference between these. You can see ongoing per transfer, 55% on the receptive day when this is standard window, or almost 59% of ongoing per transfer when we are personalizing the embryo transfer, because we are transferring in both cases at the receptive day of the endometrium. And it is very important, and I would like to highlight here that this rate of ongoing per transfer is achieved on recurrent implantation failure patients. I mean, this patient has 3 or more previous failed attempts. So this is a very high rate for ongoing for this type of patients. Then I want to show you what happened in first visit patients, because we published it in 2020 and randomized clinical trial, but performed it just in patients of good prognosis. This is first visit patients. This study was divided in 3 branches. The first one were patients that had the ERA test performed and then the transfer of cryopreserved embryos in an HRT cycle guided by the ERA result. The second branch were transferred also with cryopreserved embryos at HRT cycle, but all of them at P+5. And the third one was a fresh embryo transfer performed in the same ovarian stimulated cycle in which the oocytes were obtained. This is the table with the clinical outcome for the per protocol analysis, okay? And you can see here the result for the ERA branch, then the result in the second column for the transfer at HRT without ERA, and then in the third column you can see the transfer in fresh cycle. As you can see here, the pregnancy rate is higher when we are applying the ERA test. Indeed, it is statistically significant if we compare with just transferring a P+5 in all of them, and almost significant if we compare with fresh embryo transfer. Similar happen with implantation rate. Also, we see here that it is higher when we apply ERA, and in this case, it is statistically significant when we do both comparison between HRT cycle, all of them at 3+5, or with fresh embryo transfer. However, the live birth rate at the first attempt was not statistically significant, but we can see here also a trend because it keeps being higher in the ERA branch. When we go to the cumulative data, after 1 year of attempts, we see that both pregnancy rate and live birth rate are significantly higher when we are applying ERA when comparing with both, with HRT cycles, all of them at 3+5, or with fresh embryo transfer cycle. So this is what happened when we have patient at the first visit. But also I want to share to you one of the last publication that has been published this month. This is in 281 patients from a clinic in China, okay? And this is a retrospective study in which the clinic compared patients, 140 patients that had ERA, patients with recurrent implantation failure, against patients with recurrent implantation failure, but without ERA. As you can see here, it is statistically significant, the three main outcome measures, implantation rate, pregnancy rate, and clinical pregnancy rate, being higher when ERA is applied. There are several publications related to the clinical outcome obtained when using ERA. Not only publication performed by our group in genomics, but also external publications from clinics that are using our test. Indeed, from 30 scientific publications showing clinical outcome, there are 7 internal from genomics and 23 external publications. Finally, I just want to share with you the conclusion of this presentation, and this is that the endometrial factor plays a key role during the implantation process. I mean, we have not just to focus on the embryo, but also on the endometrial factor. Although most of women are receptive at the standard window of implantation, some of them can reach receptivity earlier or later, so we need to adjust the embryo transfer moment in these patients. To increase the probabilities of getting pregnant, it is important to synchronize the viable blastocyst ready to implant with the receptive endometrium, and this is done through the personalization of the embryo transfer. So thank you all for attending this webinar, and now I'm going to open the question and answer section. So please write as Vikram requested to you in the square for the question, and I will answer you.
Thank you very much, Dr. Maria, for this lovely and informative presentation. I'm sure the audience would really replicate my thoughts on this presentation of yours. And I would also like to thank the audience for sparing their time, because I know in India this time, like between 6 to 7, it's always hectic for doctors. Either they are in their clinics or they are driving home. So thank you very much, entire audience here. So Dr. Maria, we have some questions already with us from some of the doctors in the audience. I'll be reading out the questions to you and seeking your, kind reply. The first question is from Dr. Paresh, and he's asking why repeat sampling is required in ERA. And along with this question, he has another question. How much sample should be collected during biopsy? Is there any criteria for sample collection which they should follow strictly?
Okay. Well, let me answer first the first question. I want to use one of the slides of the presentation to show why sometimes we need a second biopsy to validate the result. This is because of that, okay? As I have shown you, when we obtain a pre-receptive result needing just one more day with progesterone, okay, this is when the biopsy is collected at P+5, and the recommendation is that the patient is going to reach receptivity at P+6, just one day later, we see that 89% of patients reach receptivity after following this recommendation. So in these cases, it is not needed a second biopsy. But when we have a biopsy that results pre-receptive and the predictor indicates that the patient needs 2 more days with progesterone, then what we see is that there is 70% of patients that reach receptivity. But there are 30% of patients that are not going to reach receptivity after adding these 2 extra days. This is because some of those patients will have a narrower window of implantation. So maybe with these 2 days, they will go to post-receptivity. Or also because there are patients that has a slower endometrial answer than the standard, and they will keep still being pre-receptive after adding these 2 extra days. So there is a 30% of patients that can suffer these 2 conditions to keep pre-receptive or to go to post-receptivity, is why when we obtain this kind of result, pre-receptive needing 2 more days with progesterone, we request a second biopsy. Similar happens when the result is post-receptive. What we see here, it is usually related with narrow window of implantation. And we find that 60% of patients reach receptivity after resting one day with progesterone, but there is 40% of patients that can keep being post-receptive or that goes to pre-receptivity because their window of implantation is narrower than 24 hours. For that reason, because there are 40% of patients that has this condition, is why also when we obtain a post-receptive result, we recommend this second biopsy. But this just happened, as I am going to show you here, in a very few percentage of cases when we obtain post-receptive, that is not much frequent, or pre-receptive needing 2 more days. This is the only 2 kind of results. Well, proliferative, but it is happening like than 0.5% of cases, in which we recommend a new biopsy. In these other categories, we are not going to request any validation biopsy additional. And also, I think that your question was about how many biopsies to collect in the first cycle could be, Vikram? Vikram?
Sorry, I was mute. Sorry, I was mute.
Yeah, how much samples will be collected, right?
Yeah. How much sample
Yes.
should be collected?
Okay, we recommend just to collect. There are some doctors that ask if they can collect 2 biopsies within the same cycle, maybe progesterone +5 and progesterone +7. So maybe they can avoid a new cycle in case that they will need to have this kind of result. However, which is the problem, that we cannot predict if the patient is going to be pre-receptive needing 2 days or post-receptive. So I don't recommend to collect 2 biopsies in the first cycle, just 1 biopsy, always at the standard window of implantation. And regarding the quantity of tissue that has to be collected, our recommendation always is around 70 milligrams of tissue that more or less is not more than 1/3 of the total volume of the cryotube. With this quantity will be enough. But just collecting 1 biopsy. There is only few cases in which we can recommend to collect 2 biopsies within the same cycle, but it will be for specific cases in which, based on a previous result, we can assess to the doctor and to recommend to collect 2 biopsies. But for the first biopsy in a patient that it is the first time doing the ERA, we always recommend just 1 biopsy.
Okay. Now there is third question from Dr. Paresh only. Is there any criteria for sample collection? Like, I don't know, this is a bit generic question. So is there any criteria are there any recommendations from your end while collecting the sample? What should be the methodology and all that?
Yeah, the methodology is a normal procedure as the same that collecting endometrial biopsies for the other kind of analysis. But there is some requirements. I mean, First of all, it has to be used our kit, a specific kit, with a cryotube in which the sample has to be introduced. We have this requirement for the sample volume. It has not to be more than 1/3 of the total volume of the cryotube in order to ensure that the preservative liquid that is inside of the cryotube is going to be enough for the tissue collected in order to preserve the genetic material. Also, it is needed that after collecting the sample, it has to be kept in the fridge during 4 hours at least, to allow the preservative liquid go inside the tissue, so then the sample can be sent at room temperature. Also, it is important, as I mentioned it previously in the presentation, that the first biopsy has to be collected at the standard way of implantation, window of implantation, which will be P+5 in HRT cycle or LH+7 and HCG+7, and also a proper control of endogenous progesterone. But all these indications are well described in our manual, so they won't have problem to understand which is the specific requirements to collect an ERA biopsy.
I would also request Dr. Paresh that you can always get in touch with us if you require any further information about ERA, or you can just put in your mail ID here in the question box or in the chat box so that we can reach out to you. Thank you very much for your questions, Dr. Paresh. Another question is, there are two doctors who have asked a similar question. One is Dr. Bhagyashree, another is Dr. Shobna. They're asking why we cannot perform ERA in stimulation cycle.
Okay, this is because in a stimulated cycle, there is a higher variability of the hormones intercycle. So we cannot ensure reproducibility of the result between two different stimulated cycles. For that reason is why we recommend only to do the ERA on HRT cycle or natural cycle, because if you do the biopsy on an ovarian stimulated cycle and then perform the transfer in a different ovarian stimulated cycle, maybe you are not going to have a proper reproducibility of the result because of this variability on the hormones that it is difficult to control. So this is the main reason.
And I'm sorry, I forgot to add the name of Dr. Ayesha. She has also asked the same question, that why ERA cannot be performed in controlled ovarian stimulation cycles. I'm sorry for that, Dr. Ayesha, because I just noticed your question. Now, there is another question from Dr. Ayesha only. Which drugs will affect the endometrium? If Dr. Ayesha, you can be a little bit more specific about this, what kind of effect are we looking at? You mean adversely affect the endometrium? Dr. Maria, could you gather anything? Which drugs will affect the endometrium?
I think that maybe the doctor is referring to the fact that that could affect the ERA result. I mean, usually what we say is, to be conservative, is that all the medicaments that are going to be used during the transfer cycle should be replicated during the biopsy cycle. This is in order to avoid any possible artifact that could affect the reproducibility of the result. But really, not all the additional medication are going to affect the reproducibility of the ERA result. But yes, it is going to happen for those medications that has hormonal interaction. For example, if you are going to use a steroid or corticosteroid or something that could interact with the hormonal metabolism, it could affect the reproducibility of the result. But even with that, we recommend to try to replicate exactly the same additional medication in both in transfer and in biopsy cycle. So we are going to be sure that we are replicating exactly the same conditions. And also there are some questions that we receive about if a patient has an ERA biopsy performed and then some months later, they decide to do a specific treatment for the patient that is going to be used in the transfer cycle, and they don't know if maybe it's going to affect to the reproducibility of their cell of their previous era. In such cases, we need to analyze each specific treatment, and for that, we are open to receive any consultation. So in case that you have any case like this, the best option is just to ask us directly for that specific medicament or treatment, so we are going to give you a personalized recommendation.
Okay, thank you very much, Dr. Maria, for your reply. I hope the doctor got the correct one. Now, Dr. Priya. Hi, Dr. Priya. Very good evening to you. She has a question. What is the optimal progesterone value on the day of trigger during ERA cycle?
You mean in the day of the biopsy?
Yeah.
Okay.
Day
we
of
are
trigger.
Not... Sorry?
Day of trigger. This gives me a sense that, you know, some kind of trigger is given in order to take during the ERA cycle. So
Yeah, okay.
What would be the optimal progesterone value?
If the doctor is meaning in a natural cycle in which it is given HCG for triggering the ovulation, then the optimal value of endogenous progesterone should be less than 1 nanogram per milliliter, because we have to be sure that there is no endogenous progesterone affecting the endometrium prior ovulation. So at HCG plus 0, or the day of the triggering, the endogenous progesterone must be less than 1 nanogram per milliliter. Otherwise, our recommendation is to cancel the cycle.
Okay. Okay. Thank you.
You're welcome.
Dr. Maria, we have another question here from Dr. Selvi. She is asking, what is the validity time of an ERA report? Because in COVID scenario, Dr. Selvi has not performed any ERA procedures due to pandemic. So what is the validity time of an ERA report?
Okay, what we have validated in a study in 2014 is that the ERA can be reproduced up to 36 months later. But it is important that we accomplish some specific issues. First of all, is that the patient has not to have any uterine surgery intervention between the ERA cycle and the transfer cycle, because maybe if you perform the ERA and then 1 year later you have a myomectomy, then it could affect to the previous result, okay? It could affect to the endometrial answer. But if the patient has not any surgical intervention between the biopsy and the transfer, if there is no change on the BMI, and if the protocol is fully replicated exactly the same and with a proper control of endogenous progesterone, then it is validated that you can use the biopsy up to 36 months later. This is the time that we have validated, but it doesn't mean that it is the only time in which the result is replicable, but it is the specific time in which we validate it.
Thanks again, Dr. Maria. Now, Dr. Priya again has another question. Some centers do day 4 morula transfers. Just a second, I missed this question. Yeah, some centers do day 4 morula transfers. Does ERA have a role then in decision of day of the transfer?
Yeah, what we recommend always is to adjust the moment of the transfer according to the moment in which the endometrium is going to reach blastocyst stage. I mean, if you are going to transfer an embryo that needs 1 more day at least to reach blastocyst stage, then you have to transfer it 1 day earlier than to reach the receptive phenotype. So a patient which is receptive at P+5 and then is going to have a transfer of a day 4 embryo, it should be done at progesterone +4, 1 day earlier. And if it is a day 3 embryo, it has to be done 2 days earlier than the receptive day. But once the embryo has reached the blastocyst stage, independently if it is on day 5, day 6, or day 7, all of them are transferring at the same moment, which is during the receptive phenotype.
Thanks again. Dr. Rajeshri has a question which you already have addressed. That is the validity of the error report, error result. How long is the validity of the error result? So I hope Dr. Rajeshri has got the reply of her question, because the same question was read out to Dr. Maria a few moments back. But thank you very much, Dr. Rajeshri, for your question. And then this is Dr. Selvi again. She's asking about GCSF. GCSF, Maria, is actually, you must be knowing, granulocyte colony stimulating factor. This is used to, I think, for endometrial proliferation thickness, increasing the thickness of the endometrium, if I'm right. So she's asking, sometimes GCSF is instilled in the PET cycle. Will it alter, because the usage of GCSF, will it alter the window of implantation if it is not done in ERA cycle?
Well, we cannot be sure because, as I have mentioned, we have not specific recommendations. Sorry, 1 second. There is no, we have not validated specifically the use of this medicament in different cycles to see if it affects or not reproducibility, but it could affect. So our recommendation will be, in order to be conservative and to avoid any possible artifact, because we cannot discard an effect 100%, to replicate, if it is going to be used during the transfer cycle, to use it also on the ERA cycle.
Okay. Thanks a lot. We have Dr. Aisha, and her question is, should we do ERA followed by hysteroscopy or hysteroscopy followed by ERA? What intervention effect will it have on the ERA report?
Yeah, what we recommend is, in case that you are going to perform an hysteroscopy, if it is going to be just observational, you can do the ERA at the beginning of the procedure, prior distending the uterine cavity, okay? And then you can do the hysteroscope. But if you are going to do the hysteroscopy in order to possibly removing some polyps or myoma or correcting a uterine septum or something like that, then you have to do the biopsy and the hysteroscopy in different cycles. And you have to perform first the hysteroscopy to do the intervention, and then in a different subsequent cycle to do the biopsy, because that intervention could affect the endometrial answer. So in order to ensure the reproducibility, our recommendation will be a cycle with the hysteroscopy and the intervention, and then in a different cycle after that do the ERA biopsy. But if the hysteroscopy is just observational and it is not going to be removed any polyp or myoma or any other issue, is just to observe the endometrium, to diagnose, or there is no an intervention, then you can do the biopsy in the same day, just at the beginning of the procedure, prior distending the uterine cavity.
Great. Thank you very much. I hope the doctor got the reply. Well, Dr. Paresh has another question. A patient with recurrent episode of fluid in endometrium and with thin endometrium around 5 to 6 mm. So what to do with this patient? Recurrent episode of fluid in endometrium, and on top of that, the endometrium is thin. That's around 4 to 5 or 6 mm.
Well, usually when there is fluid on the endometrium, usually it could be related with a kind of infection. So in this case, our recommendation will be to do an ENMA test to verify that there is no infection, and in case that there is an infection, to treat it, and then after treated, to do the ERA test. But if it has been proven that there is no infection and it is not going to be treated, then they can go ahead and perform the biopsy, because the conditions for the transfer are going to be the same, because there is not going to be treatment. But if it has not been tested an infection, our recommendation will be first doing an ENMA to check if there is an infection that is causing this fluid, and to treat it accordingly according to the result.
Thank you. This is a question, Maria, from Dr. Sandhya. She's asking, can we perform Emma LS along with ERA in the same sample?
Yes, indeed. You can. We have these 3 tests, okay? Endometrial receptivity analysis, just to check when they perform the transfer. Then we have ENMA, which we are going to analyze the whole microbiome in the uterus. And then we have ALICE, that it is a part inside of ENMA, in which we are going only to detect those bacteria related directly with chronic endometritis. You can select to do one of these 3 tests or do the 3 of them in the same sample biopsy, because we are going to, from the same piece of tissue, we are going to extract the RNA for the ERA analysis and the bacterial DNA for the ENMA analysis. So we can perform the analysis of these 3 tests from the same sample.
Thank you. And well, we have Dr. Samina. She has asked a question which already has been replied by you. Why ERA biopsy is not performed in COS cycle? So I'm sure she has got the reply to this question of hers. And Dr. Samina has another question, and I think this too has been addressed, if I'm not wrong. Which are the drugs that can affect the ERA biopsy? Can you shed some light on this, Dr. Maria?
Yeah, it is what I have explained it before. The drugs or the medication that could affect the ERA result are those which have hormonal interaction, because at the end, what we are detecting is the behavior of the endometrium as an answer to the progesterone. So any drug or any medication that could interact with progesterone or with estradiol, or could have an indirect effect on these hormones, could affect the ERA result. For that reason is why we used to be conservative and to request to replicate all the drugs or all the medicaments that are going to be used during the transfer cycle, the same for the biopsy cycle. Because at the end, there is no specific drugs or medicaments that can affect ERA itself, but can affect to the reproducibility of the result. And for that reason, if you are going to use it during the transfer cycle, no problem, just use it also during the biopsy cycle.
Okay. I would request Dr. Ashwin if he can report his question, because it's somehow incomplete. You know, it's not a complete question. May I request you to again put your question forth? Then there is this question from Dr. Paresh again. Is there any specific wall of endometrium from where you recommend the collection of the biopsy?
Yeah, it has to be collected from the fundus of the uterus.
Okay.
We have seen, really, this is not a... Sorry?
Yeah, please carry on, Maria.
Yeah, this is not a big issue, because recently we have done a study in which it was analyzed the ERA result from the proximal part of the uterus, then the medium, and then the distal, the fundus of the uterus. And we see that there were a good correlation of the result. I mean, there were no difference. But as maybe at the end we are going to guide the transfer at the fundus of the uterus, our recommendation, standard recommendation, is always connecting the biopsy at the fundus of the uterus.
Thanks, Maria. Well, we have Dr. Supriya. She has a question. If there is an indication for ERA in diminished or poor ovarian result.
Can you repeat, please?
Is there any indication for ERA in patients who have poor ovarian reserve?
Well, Not specifically, because we have not detected a relationship of higher risk of displaced window of implantation in this kind of patients. Just in case that this patient has maybe just one embryo obtained or something like that, or it comes with several previous failed attempts, then it will be an indication, but not just for the reason of having PCO. So poor ovarian reserve. This is just in case that maybe if you have stimulated the patient and you have 3 viable embryo, then you could do a first trial, a first attempt, and if it doesn't implant, then to perform ERA, because you know that you have just 2 remaining embryos and you don't want to lose the good embryos. So this will be the reason, but not because we have detected our direct relationship with a higher risk of displaced window of implantation. It will be just an indication in order to save the few number of viable embryos that this patient could have.
Thanks, Maria.
You're welcome.
Maria, we have this question from Dr. Swapna. Is ERA result still valid if the patient conceives after personalized embryo transfer, but unfortunately results in miscarriage? Is the ERA report still valid in such cases?
Well, the question is if after a miscarriage we can keep using the previous result, or
Yes.
do you mean if ERA will be an indication for patients with miscarriage?
No, I think the first one, whether the report would hold valid if the patient has miscarried after PET.
Yeah, it won't be a problem. I mean, you could the ERA will be still replayable, unless that after the miscarriage you have to do a curettage and maybe the patient has it has led to an atrophic endometrium, you know, like a Asherman syndrome or something like that. But if not, and the procedure has gone well and the patient is properly recovered, then you can keep using the previous ERA report.
Wonderful. We have Dr. Shobna. She's asking, is ERA indicated in PCOS? What is its role in patients with uterine malformation? Does ERA has a role in patients who have, uterine malformation?
Yeah, this will be indicated because we have found that there is not published, but by our internal data, we have seen that patients with uterine malformation has higher rate of displaced window of implantation. So it will be also an indication. But it is important that if it is going to be performed an intervention to correct this malformation, then the ERA should be done after the intervention.
Mm-hmm. And what about the role of ERA in polycystic ovarian syndrome? Does it has any role?
No, because we have not seen relation between this kind of patients and a higher risk of displaced window of implantation. So this is not an indication unless this patient has a previous recurrent implantation failure.
Okay. We have Dr. Richa. She has asked a question. The question reads like this: is ERA also relevant for those patients with multiple biochemical losses where
Yes.
embryo factor was not suspected?
Yes, indeed, this will be also indication for ERA. We have a publication in 2017 in which we see that to be transferring at the end of the receptive period, this is late receptive, during the late receptive, there is a higher risk of biochemical pregnancies. So if you have a patient that in which you have discarded the embryo factor, but she keeps having biochemical pregnancies, she has a higher risk of having a late receptive endometrial profile. So it will be indicated to do the ERA to correct this.
Okay, thank you. Thank you, Maria. We have Dr. Swati. Her question is, in thin endometrium, if we won't get good amount of sample, what will be the solution? Because this is a common thing that many patients, Dr. Maria, have very thin, consistently very thin endometrium. So what is
Yeah.
the solution if doctor decides of putting the patient through error?
Yeah, it is difficult because in these cases, we know that the risk of not having enough tissue to perform the test is very high. And this is not an easy solution because it is just, we are talking about quantity, and if there is not enough, it is not possible to do nothing. What we recommend in those cases is if they go with pipelle and then collect the biopsy and they introduce in the cryotube and they see that it is not enough, they can try to entry again to the uterus and to try to collect again a new quantity of sample and introducing it in the same cryotube in order to try to increase the total volume of tissue. But there is no any other specific recommendation. In those cases, at least, for example, a patient that has a sample with not enough RNA, maybe we can process the sample and you can see a transcriptomic profile, but not trustable because of the quantity of the RNA. But if the patient has a second biopsy and we analyze again and there is the same problem, not enough RNA, but we detect the same trend on the transcriptomic profile, maybe although we cannot release a valid diagnosis, we can assess to the doctor about the trend observed. So this is just what we can offer. I mean, in these specific cases, they can reach us and we are going to guide, personalize it, and we are going to try at least to explain if we see any kind of trend, although we are not able to obtain a valid diagnosis. But we have not any specific recommendation to obtain more tissue because the problem is that there is not more tissue that they can take.
Well, Dr. Maria, for the benefit of the audience, and this is a question from me also, how much thin are we talking about here? Thin endometrium. Can you tell us in millimeters that less than this millimeter error should not be performed? What is that thin endometrium? Can you specify?
No, yeah, ERA can be done at any endometrial thickness, okay? I mean, we classify the endometrium in three main categories. Atrophic, if it is below 6 millimeters, normal, if it is between 6 and 12 millimeters, or hypertrophic, if it is more than 12 millimeters. But you can do ERA with any thickness. The only requirement is that you have to collect the biopsy when the endometrium is going to have a similar thickness than the one that you expect to have for the transfer cycle. For example, if you have a patient that always reach 8 millimeters, 9 millimeters, and then you plan to do the ERA, but in that specific cycle, the endometrium is not growing and it is just 5 millimeters, then cancel the cycle. Because most probably you do the ERA, the result is not going to be replayable because you are collecting the biopsy when the endometrium is atrophic, but if your patient has good endometriums, for the transfer cycle, you are going to have a normal endometrium. So we cannot correlate result from atrophic endometrium to a normal endometrium. But if your patient in a consistent way never reach more than 5 millimeters, for example, there is no problem. You can do the ERA, and indeed it will be indicated to do the ERA because these kind of patients with 3, 4, 5 millimeters have a higher risk of having a displaced window of implantation. But you can do the ERA at that thickness because you are going to face similar thickness in the transfer cycle. Maybe you are collecting the biopsy with 4 millimeters, and in the transfer cycle you are going to have 3.5 or 4 millimeters also. So you can extrapolate the result. But there is not a minimum of endometrial thickness to do the ERA. The only requirement is that this thickness has to be similar between endometrial biopsy cycle and transfer cycle.
Thanks a lot, Maria.
You're welcome.
Again, Dr. Paresh has the, it is a question in continuation of his last question, which you have already replied, I presume. In fluid with endometrium, at which day we should prefer the biopsy day? If there is a fluid on the day of biopsy, what can we do?
If this is what I have mentioned, the day of the biopsy has to be always the same. This is P+5 on HRT cycle or LH+7, HCG+7 on natural cycle. If it is not possible to do the biopsy at that day, then it is better to cancel the cycle and start a new one. If the problem is that in this specific cycle there is fluid, you have to cancel the cycle. But if the problem is that the patient has fluid in all the cycles always at this same moment of during the mid-secretory stage, then the doctor has to evaluate if he or she is going to treat the patient or not, and according to that, to plan when to do the biopsy. But if it is a case in which the patient used not to have fluid, but then when you are going to collect the biopsy, you find that there is fluid, then it is better to cancel the cycle and start a new one instead of delaying the biopsy collection one day. Because if you collect the biopsy at P+6 instead of P+5, which is the recommended day, you will have higher risk of obtaining a post-receptive result and then to need to do a new biopsy at P+5. So it has not too much sense. It is better to cancel and to wait until the proper day to collect the biopsy.
Well, Dr. Swapna has a question which you already have replied to. How many months is the validity of the error report? I think this has been addressed earlier.
Yes.
Dr. Surgeon has a question. He's asking, how do you validate your error test, and how many samples, and what is the reference material?
The reference, well, we can share the reference because there are several publications. We have the first one, which is from 2011, in which we published how the test was developed. But also there is a thesis project in which it is completed information presented on that paper. We use more than 200 samples per category at the end in the thesis project. And then we have other kind of validation like reproducibility validation, which is the paper from 2014, and then clinical validation, showing clinical outcome after personalized embryo transfer, in which we can see these 30 reference, 30 publications, 7 internal and 23 external. For us, will be a pleasure to share with any doctor that require this all our reference, so they can have this list of reference to check the papers that they want to check. Just write to us and we will send to you the list.
Thanks, Dr. Maria. Dr. Priya, again, she asks, have you correlated serum progesterone levels on day P+5 with outcomes in cases of error?
Yeah.
What is the optimum progesterone value for maximum successful outcomes?
Yeah, there is an issue that did a pilot study in 2015 in which we didn't detect any correlation between the progesterone value in the day of the biopsy and the error result. 1 year ago, another clinic in an external analysis had the same result. There is no correlation between the serum progesterone level at the day of the biopsy with the error result. So we have not taken account the progesterone level at P+5 during the transfer to take any decision. But we are aware that there are some publications, recent publications, in which they are talking about a threshold of endogenous progesterone level at the day of the transfer, and that if the level is below of that threshold, the clinical outcome could be affected. So our recommendation is if you are used ERA to guide the transfer, and then you are going to perform the transfer, for example, at P+5, guided by ERA, but you find that at that day, the endogenous progesterone level is below from the threshold that you consider, you can increase the progesterone dose, but the subsequent day at the embryo transfer. I mean, if you transfer the blastocyst at P+5, then you could increase the progesterone dose at the following day at P+6. Because if you increase the dose of progesterone prior of the transfer, then most probably the reproducibility of the result will be affected, because not all the patients answer in the same manner to different dose of progesterone. So maybe you have a patient that you are giving 600 milligrams of progesterone, and then you increase to 800, and she answers in the same manner. She keeps being receptive at the same moment. But there are other patients that answer differently to different dose. So maybe you could have another patient that has 600 milligrams of progesterone per day, and she is receptive at progesterone plus 5, but if you increase the dose, then she will be receptive earlier. So for that reason, we don't recommend to increase the progesterone dose prior the transfer. But in case that you want to increase it because the level of progesterone is lower than a specific threshold in the transfer day, you could increase it at the subsequent day, the day after the transfer. This is our recommendation.
Thank you, Maria.
You're welcome.
Dr. Selvi has requested you to explain to her, and for the entire audience, of course, error in natural cycle.
Yeah, error can be collected in natural cycle, and there are two main possibilities of collecting the error in natural cycle. This is based on LH surge detection or with HCG triggering. If you are going to collect the error on natural cycle based on LH surge detection, our recommendation is to measure LH on blood or on urine during several following days, obtaining at least one positive flanked by two negatives. Then you know where is the specific date for the LH surge, and this will be considered LH plus 0. And the biopsy will be collected at LH plus 7 days later. On the other hand, if you are going to collect the sample in a natural cycle, but you are going to trigger the ovulation by using HCG, then the day of the HCG will be considered HCG plus 0, and the biopsy will be collected HCG plus 7. In both cases, you can supplement with exogenous progesterone. We recommend to add it from HCG plus 2 or from LH plus 2. And then also we recommend to control the endogenous progesterone value that has to be less than 1 nanogram per milliliter at LH plus 0, the day of the LH surge, or at HCG plus 0, the day of the in which HCG is using to trigger ovulation. But they can find more specific detailed information about natural cycles and how to collect the biopsy in our manual. It is very detailedly described.
Thanks, Maria. Well, we have Dr. Priya again. Does it matter? The question reads like this. Does it matter which day the blastocyst was frozen, whether it was day 5, day 6, or day 7? And it can still be thawed and transferred on P+5.
Yeah, it doesn't matter. I mean, as I have mentioned, if you have a blastocyst in day 5, day 6, or day 7, you can transfer all of them at the same moment, which is the receptive day. And if you have freeze the embryo at day 3, then you can transfer the embryo at day 3 2 days earlier than the receptive day, or thaw the embryo, keep developing until reaching the blastocyst stage, and then transferring it in the receptive day of the endometrium. It doesn't matter.
Thanks again. Well, please be patient with me, Dr. Maria. Your presentation was wonderful. Thus, we have a lot many questions. Dr. Nirmala is asking, does the error window change after a miscarriage or after delivering a baby?
We have, at the moment, we have not see a clear correlation about that. So our recommendation is that, as I have mentioned it before, if there is no accurate deaths after a miscarriage, for example, that could have led to an Asherman syndrome or some atrophic endometrium, it shouldn't be affected, the error result. I mean, it shouldn't be different than the previous error. But we want to study this. I mean, we have on carry on now, but not still ended, a project in which we can analyze which is the effect of the pregnancy after ERA and the delivery. Because we have a lot of cases in which there is no chain. I mean, we have a lot of cases in which they had a biopsy, then the transfer, successful pregnancy, then delivery, and then they repeat the biopsy and it has the same result than the previous one, or that they directly recommended the previous biopsy and they get pregnancy again. But also we have found some cases in which there is a chain on the window of implantation. But as these cases were not under a proper study, we don't know if it was due to the pregnancy itself or to variation in any other variables that could affect the error result. So for that reason, we want to carry on a study in which we can control all the variables and then to finally be sure about if it affects or not, or maybe some patients or maybe none of the patient. But by the moment, our recommendation is that if your patient has had a pregnancy and a delivery, you can keep following the previous error result, unless the case that your patient has just one remaining embryo. So maybe in that case, if it has passed 1 or 2 years and you want to validate the error prior of using this last embryo, you could repeat the test. But in theory, at the moment, with our consideration is that pregnancy doesn't affect the window of implantation, at least not to all the patients.
Thank you. Dr. Swapna, the question is, do we have any data on success rate after transferring day 3 embryos with displaced window of implantation after ERA?
Yeah, we have not released it because we have not many data about that, but our internal data sustain that there is no difference between transfer with day 3 embryo or transfer with blastocyst stage, because at the end, when we transfer day 3 embryo, we are doing it 2 days earlier than the receptive day. So for example, imagine that your patient has a displaced window of implantation and she is receptive at P+7, okay? You will have to transfer a blastocyst at P+7 and a day 3 embryo at P+5. But we at the moment on our internal data, we have not seen any difference on when following the recommendation for day 3 embryo than for blastocyst.
Thanks, Dr. Maria. Well, Dr. Priya is back with us, it seems. She has a comment regarding PCOS with obesity.
Obesity.
So patient, yeah, obesity. So she says ERA is very useful in such patients.
Yes.
Because,
yes.
You may find some PCOS patients who have thin endometrium. So she might have done some cases on PCOS patients with thin endometrium. Your comments, please, Dr. Maria.
Yeah, indeed, the patients, as I have mentioned, patients with obesity, with a high BMI over 30, we have detected that they have a higher risk of displaced window of implantation. So patients with obesity of high BMI or patients with thin endometrium, it will be an indication to do the ERA, because we know that there is a higher proportion of patients with displacement of the window of implantation. So it is a very good indication to perform ERA on those cases.
Thanks. Dr. Ashwin is here with us. Thank you very much for your question, Dr. Ashwin. Could you please, the question reads, could you please explain how to proceed with ERA in patients with thin endometrium? In case, this has already been replied, but in case, the specific is here, in case insufficient sample is obtained.
Yeah, in that case, we need very low amount of RNA quantity to process the sample. So maybe you are collecting the sample and you think that there is not enough tissue. You, as I have mentioned it before, can try again in the endometrium and to try to collect a second sample and then introduce it in the same tube, because they are collected at the same day. But always send to us the sample, because we never know if that maybe with you have obtained a very few quantity of tissue, but maybe it could be enough. So our recommendation is try to get as much as possible, but it is not possible and it is very few, you can keep sending to us and we will try to analyze. If there is not enough RNA to proceed, then the analysis won't be billed, and then we will request a new biopsy. But if we observe a trend, we can guide with that information in case that the patient doesn't want to repeat the biopsy. But there is no other specific recommendation than to try to get as much as possible the tissue, always not more than 1/3 of the total volume of the cryotube, and we will try to do as much as possible to be able to analyze the sample.
Last two questions, Dr. Maria, then I'll let you off. Dr. Lalita, she has a question. After ERA patient had failed IVF, followed by spontaneous conception, which was unfortunately an abnormal baby, right? And that was terminated. That baby was terminated. Failed IVF, followed by spontaneous conception, which resulted in an abnormal baby, but that baby was terminated. Now the question here is, does the ERA report hold valid for next cycle?
Yes, I have mentioned it. It will be the same than natural miscarriage, even if it is terminated. If it is not an effect over the endometrium at the aspect, this is not an thinner endometrium or something that could have affected directly to the endometrium, the ERA will be replayable still.
Thanks. Well, last question is from Dr. Prabodhini. She's asking, Dr. Maria, can you explain about the ERA decision tree? How do you decide? Now, this is the patient who requires ERA. What steps? What tree do you make?
Yeah, this is very simple. This is just if you are going to do the ERA, just collect the biopsy at the standard day of the window of implantation, and then you will have two possible options. Maybe you are going to receive a result with a direct recommendation for transfer, and then you will go for the transfer, personalizing the day of the transfer, or maybe you can obtain a recommendation for a new biopsy. In that case, you will have to do a new biopsy on the recommended day, and most probably with that second biopsy you will obtain the recommendation for the transfer, so you will go for the transfer. So there is no any complication, just collecting the biopsy at the standard day of the window of implantation, and then or to transfer according to the result, or to perform the new biopsy according to what it is indicated in the report.
I'm sure, Dr. Prabodhini, this was your question, if we have not misinterpreted it. Well, another one, Dr. Supriya. Has a relationship been established between serum progesterone level and ERA result? That is, progesterone and receptive endometrium. If ERA tells us that the endometrium is receptive and vis-a-vis progesterone level, what relationship have we established? Void our studies and
yeah, as mentioned before, we did a study at 2015, and we detect that there is no correlation between the endogenous progesterone level at the day of the biopsy and the ERA result. So we have not seen any trend regarding higher progesterone, higher receptivity, or something like that. There is no relation at all. And also it was checked again in an independent study 1 year ago that they obtained the same result. There is no correlation between the endogenous progesterone level at the moment of the biopsy and the ERA result.
Okay. Thank you very much, Dr. Maria. We have already exceeded the time frame by half an hour, but this was essential. A wonderful presentation, and thank you very much for patiently taking up the questions and replying to each and every question in detail. Gratitude to you, and my sincere thanks to the entire audience. I can understand. This was a time when you would have been very busy. But thank you very much for sparing your time. I assure you this is the practice that we follow in iGenomics, that is education and educating the doctors, our clients. So shortly we will have another webinar. You'll be kept posted. If you have any remarks, please mail it to us. If you require anything pertaining to today's subject area, please mail it to us. We'll be, taking up your mails, and replying to you as early as possible. So thank you very much, everybody. Have a good night. Thanks, Dr. Maria, again, and thanks, NG, who is behind the curtains. So thank you very much, NG, for organizing the whole webinar. Really, you have always been so much instrumental and important. Thank you very much for your support.
Thank you so much, Vikram. Thank you, Dr. Maria.
Thank you
Thanks,
all.
everybody. Bye.
Bye.
Bye.